When we think about vascular access and what type of line we are going to place for the patient, we need the right line at the right time for that patient population. Some of the considerations: prescribed therapy. What will they be prescribed? Treatment. How often will they be receiving this medication? Duration of treatment. That's a big one when we are thinking about the vascular access device that we will be placing into this patient. Comorbidities and patient history of vascular access and infusion therapy. Have they had the therapy before? Is this a known patient? Are they on the do not attempt list? I'm not sure if some of your facilities, entities where you work, we do have do not attempt list, and they are extremely helpful. For some people that are doing the database, we're hoping for a section that will populate on that. This patient is a DIVA, and if you're not familiar with DIVA, difficult IV access, approved abbreviation. True. Comorbidities, people that are, diabetic, they may have that sclerosed, fibrosed vein, rolling vein. Ability to care for the vascular access device. The vascular access teams pick teams. If we know this patient's going to alternate care setting, we need to know their capability if they are going to be able to care for that device, maintain that device. Insurance plays a huge role. What are their out-of-pocket expenses? Their donut holes. Everybody's going into a new year. What will they have to pay? Golden standard, I always love this. Select the vascular access device of the smallest outer diameter with the fewest number of lumens needed to accomplish the prescribed therapy. The mark of the nurse, way back when, 1994 and so, the bigger the gauge, the better, 18. To the point where a lot of nurses will pilfer their own catheters and then work home infusion because they're very tactile. They know what catheter they want. However, putting a 20 gauge catheter in an elderly or a patient that cannot support a 20 gauge because the vein real estate, the more you take up a vein, then more complications can occur. We always talk about this in my legal review is we can really depict a legal case and basically say if it's a long-term care patient and there's a 20 gauge catheter, really the document goes no further. It's non-defendable. Write the check. How much do you want? Because it's a 20 gauge catheter. Nobody in a long-term care facility, LTAC, would truly ever need a 20 gauge catheter unless you're running blood and blood products or running a code. I trust that makes sense. And right here are some of the vascular access, once again, used. So it gives you a picture of the color. All manufacturers stay on the colored code. They're very compliant with that, so during emergency situations, they are not allowed to send to our area, FarmScript. We deal with a lot of pharmacies. They are not allowed to send any 20 gauge catheters to any long-term care because we don't want those incidents on that. So let's talk about this short peripheral intravenous catheter, and this is just redefined by the INS. IV catheter generally inserted into the superficial veins, and I'll go in their role in a minute. Long peripheral IV catheters, now abbreviation PIVC, those are more of your extended dwells, your power wounds, your power glides. They do have a role within vascular access, but most of the time we have to use our ultrasound to place those longer devices, and we have to have the vein that'll accommodate that catheter. Oh, I always like the full rates because sometimes with situations legally, they'll tell me that I needed to run a lot of fluid. If you see the gauge size for a 24 gauge catheter, pediatric catheter, very delicate catheter, it runs 20 mLs a minute, correct? 20 times 60 is 1,200. In most settings, you are not going to want to give anybody more than 1,200 in 1 hour, milliliters in 1 hour. So once you profile it like that or give them the knowledge base, because nurses can't do more unless they know more, unless you are coming to settings like this where we're able to network and learn, then you can change healthcare and practice better and have better outcomes. Midline catheters inserted into the superficial veins in the upper arm. We once again will use the basilic, brachial, and or cephalic vein for our midline catheters. Some of the extended dwell catheters can go in the lower extremity. Midlines will always be in the upper extremity. And we do use ultrasound guided for our midlines. PICC lines, peripherally inserted central catheter, a catheter inserted through the veins in the upper extremity or the neck. It depends on where, what state, your scope. Everybody's from different states here. In terms of being a vascular access nurse, if I go to Chicago, we are allowed, if there's any vascular access nurses in here, I could put a PICC line in the IJ. However, New York State, where I reside, they're very strict about that. I could be prosecuted as a criminal if I put a PICC line in somebody's IJ. So PICC lines, we use these most commonly for our long-term IV antibiotic and other therapies. We've trended in such incredible ways where now we have 3CG technology. So when I place a PICC line, let's say in a home care setting, I'm able to start the first dose because I get that confirmation of the P wave where I don't have to wait for chest x-ray confirmation. So prior to that, we had navigation and we just had to wait for the radiologist to read. So a lot of TV watching with your patients. Implantable ports. A implantable port surgically placed into the vessel, body cavity, or organ attached. Now, implantable ports are also known as infusiports, metaports, and porticats. However, our state likes you to stay away from trade names. The approved definition for that is an implantable port. So when people, unless you are truly using something that's an infusiport or porticath or metaport, but they like you to stay away from the trade names on that. And they're usually for chronic illnesses with patients with exacerbations or remission, Crohn's disease, CIDP, or cycled infusion therapies. That's our number one population for the implantable port. Central vascular access devices, your IJ catheters, your subclavian catheters. In terms of a home care setting, are we receiving these catheters? Once again, let's talk about the trade names. Subclavian, Hickman, Broviac, Hone, Cook. We have to stay away from trade names because once again, in a legal document, a nurse labeled it Hickman, the next day Broviac, and then the next day Hickman Broviac catheter. So there is no really, so it's just learning moments for all of us here in the room to realize that. Subcutaneous infusion device, one of my favorites. The reason it's my favorite is because of the long-term population, and I'll get into that shortly, but these are typically small gauge infusion devices, and they are trending now, the hypodermocliasis kits, the IVIGs. They can be inserted anywhere, not anywhere on the body, but subcutaneous spots where there's about 1.5 inch fat fold, adipose tissue. You need to be able to support that tissue will be able to absorb. Infection control, hand hygiene. I saw in the trade show we have a person there with those sharps containers. Wow, love them. Medical waste disposal. Know where you need in terms of the home, how you are going to dispose. Know your policy and procedure for durable medical equipment disinfections, those MDSD sheets. What you are cleaning your ultrasound with, what you're cleaning your blood pressure cuffs with. Standard and transmission-based precautions. With the sharps puncture proof, once again on our admission folder, we have all the information that the family will need when it comes to any type of problem with a chemo spill kit. We come in with a practice kit, we open it up so they are familiar with what's in that so they can properly cook. Can you stinking stand it? This is only one page, but we have 2 full pages. I mean, it's the most gorgeous pages you've ever seen in your life. And it's washing your hands. Single most important. I'm not going to expand on that. First dose. How many people here do first dose in the home care setting? Yay. Isn't it fun when they have a reaction? Once again, adult diaper. Depends on where you have and what you have in your parachute. All of a sudden you're looking. If first dose therapy is administered in an alternate care setting, ensure your orders are complete for emergency medication. Have your epinephrine, have your Benadryl. Sometimes you know your patients and you'll call them when you're 30 minutes out. Take your water, take your Tylenol. We know these hypersensitive. These medications must be readily available for immediate use. The clinician must be certified in CPR. I'm a CPR instructor, been for many, many, many years. Is that true in this room? For every other state? Okay. You know, I said that very broad, but I don't know if every entity makes their nurses have to be CPR certified before they send them out. Okay. Monitoring the clinician. Monitoring. The clinician must stay with the patient for the full duration of the infusion of the first dose of medication and must also stay for at least 30 minutes after the infusion is complete. Still the same? Does anybody stay an hour after, or is 30 minutes sometimes out? Okay. So right now, our policy and procedure, first dose is 30 minutes. We stay and we document.
C says 1 hour. 1 hour.
See? Love these conversations. So 1 hour. We'll have to talk about that because maybe some of us may need to change depending, validating that. Education family, where we're going. Patient and caregiver should understand the prescribed therapy. They should know the purpose of the medication, the intended outcome. Caregiver must understand their role. They are going to be one of the most important people to know their role in infusion therapy and home. They need to know who to contact and they need to demonstrate ability in participating in the care and performing. We need to document repeat demonstration. Patient did excellent, has excellent knowledge base on infusion therapy. Vascular access site must be checked at least once a day for signs of complication by the patient or caregiver. Report signs of any adverse reaction immediately. If a patient has leak and swelling of any vascular access, tell them please report it. Report dressing dislodgement, disruption immediately to the nursing agency. That way we can tell them, picture frame it, do what we need until we can make a visit out to your home to secure that line. Use caution regarding scissors, razors, or other sharp objects near the vascular access device. To be aware of this happens quite often. We are fortunate enough to be able to place the line if we need to. An education clear team, almost done. Nurses must have competency for each infusion therapy administered. That'll keep you in a safe place. Nurses must be competent in insertion, managing, and using vascular access devices. Some of you might have sent out nurses that truly don't know how to put in a peripheral IV, and then you're getting a phone call from that loved one saying, I don't know who you sent out here, but it may not be the most. Know your nurses. Know your firecrackers out there that know what they're doing. Nurses must understand aseptic technique, sterile dressing changes. Nurse must be comfortable with the variety of supplies. Once again, make sure you're giving them the catheters. They're very tactile. Nurses like to work in microseconds too. That's why we don't use betadine anymore. That's a 3-minute dry time. Nurses must be comfortable with the product they use. It'll make them so much more successful. We must adhere to all organizational policies regarding use of PPE. We've done that, we know that, and must be situationally aware of risk. Dogs, animals, stairs, guys. And I'm talking to administrative too. If there is an unsafe situation, make sure your nurses are prepared. Nurses must be prepared to arrange for additional support in challenging settings. If you see whatever gang members or dynamics, go with additional nursing or police escort. Nurses must be able to advocate on behalf of the patient and must be prepared to escalate care when needed.